Welcome everybody to another VITA Learning webinar. Today's going to be with Mr. Mark Wagenseil. Mark, how are you doing today?
Super duper. Whoop whoop.
All right, excellent. Raising the ceiling with your Wagenseil movement.
And wiggle and
the wiggle, yeah,
and
nice. You know, we're having our Thanksgiving here this week in the U.S. side, so
happy Thanksgiving.
So I appreciate you taking time out for this week to let us, give us a webinar today. So today's webinar is going to be with Mr. Mark Wagenseil, analysis, setup principles, and patient satisfaction for Class 2 removable dentures. We do get a lot of calls and a lot of different questions about, beyond Class 1. And so today's webinar is really going to give you some more insight on how to deal with those other types of classifications, the setups that, you should take a look at, understand, and then, use to your advantage the knowledge that Mark has coming from a denturist perspective from Canada. Just before we get going, a couple things. Everyone's phone is on mute. So on the right-hand side of your panel that popped up when you registered, there is a question box. Just open that up and then type in your questions. And then we'll have some Q&A towards the end of this program. Everything will be recorded. Everything will be downloaded onto the VITA website through our Instagram, through LinkedIn, YouTube, VITA North America YouTube. So the recordings of today's program, as well as past programs that Mark's provided us, are also located on that VITA YouTube channel. Please come visit us, listen to other things. We have a Class 1, of course, Mark, but then today's Class 2. This is the second Class 2 one we've done this year. We've done a Class 3 and then overbite type program. So there's many different topics that Mark has gone over with us and spent some time to let you understand how to deal with cases, real cases, that come through your laboratory as either a denturist or a technician or even maybe a dentist. We do know every once in a while we do get some dentists on, but we certainly get technicians and denturists that really love your information, Mark. So Mark Wagenseil is a denturist. He is actually a practicing denturist. So from his perspective, he actually brings to these webinars the experience of seeing the patient. Most of you that are on attending today probably don't get to see the patient. However, it helps to understand what a dentist should be looking for, or a denturist, what you're looking for, how to correct issues, how to treatment plan a case, and in this case, today's webinar focusing on a Class 2 relationship. Mark is a VITA Global Certified Trainer and Management Consultant, a licensed denturist, dental technician with over 30 years of experience. That's probably going to grow here, jump up to 35 years now soon, Mark?
Yeah, I turned 52 a couple weeks ago, so yeah, I'm getting up there.
Yeah, we're all getting older. Yeah. Mark owns and operates a laboratory called Heritage Denture Center in Edmonton, Canada, his own clinical denturist practice. Mark has spent his career focusing on how dentures integrate in the mouth and body, and he inspires a unique awareness of occlusion and professional growth of technicians, dentists, and other denturists. So thanks again. Welcome, Mark Wagenseil, denturist extraordinaire from Canada, who will guide us now through Class 2 satisfaction. Thanks for joining us, Mark. Appreciate it.
Awesome. Happy to be here. Thanks, everybody.
So I will turn this now over to Mr. Mark. And Mark, you are now the presenter. And we can see your screen.
Show my screen. Awesome. Okay. And
So
can you
I've got
see
your
the
screen up,
PowerPoint? Yep.
your
And
PowerPoint.
nice. All right. Then we're good to go.
All right.
Hi, everybody.
Thanks,
Good
Marco.
morning. Awesome. Thanks, Jim. I might check in with you every once in a while. Good morning. Hi, everybody, and welcome, and thanks for taking time out. Thanks for amping up your superhero skills for setting teeth and setting dentures. And thank you for investing in yourself and ergo the patient that trusts you. There's a patient there that's trusting you for what you do. So thanks for investing in yourself. We're here and we care for patients, and we just want the best for ourselves. And then, of course, we want the best when we deliver a denture to a patient. So thank you. We do not slap teeth together. Whoop, whoop. So that's number one for me. We don't slap teeth together. What we do is extremely technical and very difficult. So I wanted to quickly go through a PowerPoint and so that you understand a little bit of the why before I show you the how. And then we're going to jump into the how and show you a few tips and tricks. So again, thanks for investing in yourself. Common issues that we face regardless of the classification of the jaw are denture teeth break, chip, and pop off. Patients can't chew well with a denture or with a new denture. New dentures are often even more ill-fitting or loose than the old set. That happens to us a lot. My new denture doesn't fit as good as my old one. So we hear that a lot in our industry, chair side. Multiple relines with no success. Of course, the denture breaks. Food collects under the denture, but you don't need a reline, which means when we check it, the denture fits against the ridge and it's not wobbly per se, but then the food still collects under it during the chew process and the chew cycle. New dentures are feeling too big, soreness, of course, and then the temporary denture preferred over a permanent. So these are some common issues that we face building dentures for patients and that we deal with not only in the lab, but clinically as well. And trying to, again, talk that through with a patient clinically is certainly challenging on occasion. These common issues cause us stress. It's built over time. So you just have to think, you go day in, day out, week in, week out, month in, month out, year in, year out, and before you know it, you're stressed out because we deal with these common issues and problem and troubleshootings, and it wears on us, in our career. I certainly experienced that in the first, say, 5 to 10 years of my career. I left school, I was out there, I was doing it, set up my own office, and these little things just start to repeat themselves, and I got pretty good at saying, well, Mrs. Smith, it's just a denture. You have to have reasonable expectations. And I got good, and got good at trying to, just again, try to explain to people, well, what do you expect? It just sits on soft tissue. But then I started to realize, wait a minute, is this all that I have for the next 30, 40 years of my career and my life that I spend, 10 hours or 8 hours a day at the office? And I had a fork in the road where I could say, I'll accept it, or I'm going to challenge it and try to do something. So this is now me challenging it. And I'm going to share with you now my 34 odd years of doing this and some of the things that have worked well for me in making my professional life less stressful. So we have to add in a class 2 jaw relationship now into the stress because it's a little bit different and not our norm. And I'd like to just use that in quotations, not our normal, because remember, Lady Gaga said it right, baby, you were born this way. And so that's really true. You are what you are. And so it's our job and my interpretation of my responsibility of that patient trusting me. I got to mold myself to them. I'm going to try to help them. I'm not trying to change who they are. I'm there to make this work with what they are and who they are. So I want to show you and review a little bit of the why before I show you how. So Charles Darwin stated, it's not the strongest of a species which will survive, nor the smartest. It's the one most adapt to change. And that's really difficult because I'm asking you to get out of your way right now. And I'm going to show you some things that are different and new. And for those of you that are joining me for the first time, welcome. For those of you that are taking this as a repeat, welcome. So my goal is to help and inspire and to show you, again, my journey and my questioning of the norm and the textbook. So a couple of things about VITA Teeth. If you're not using them, they do follow the square tapering ovoid selection criteria. and that's through their Excel lines and through VitaPen Plus and PhysioDens. That's fairly standard. They are made, they are an acrylic glass tooth. So they're 85% polymethyl methacrylate, 14% inorganic filler, which is silica, which by definition is quartz, which by definition is glass, and 1% shade. The big thing about here is when you grind acrylic teeth, you have to polish that surface or it remains rough and then it will wear down quicker. You don't need to do that with acrylic glass, it self-polishes. So that's a big plus for me, that if I need to do anything, all I need to do is do it and not have to worry about polishing it. So you just want to make sure that you adjust it with a very fine, rubber wheel or diamond burr, something that's really, really fine when you do that adjustment to any occlusal surface of the tooth. And that's a big thing for me, is not having to repolish it after. The big thing about the glass is that it makes the tooth harder. Also, it just has that enamel characteristic to it. VITA also puts opal in their teeth. So the opalescence is like enamel. So the picture on the screen is sort of that common picture that we see of enamel teeth and the opal and the opalescence of the teeth. And so VITA actually puts opal in their teeth. And they also put phosphorus on it. So there's phosphorus in our enamel, and that's what causes the teeth to kind of glow under black light especially. But you have to keep in mind that it does that under natural light, artificial light. And so it's important that the teeth also have that, because that's life. Our bones have it, our teeth have it, and that gives the teeth the characteristic of life. And so that's why VITA puts that in as well. So it's really important. The other big thing is, just quickly, VITA teeth are golden proportioned. So golden proportioned is a mathematical principle or property that height is related to width, which is related to length and shape and arcs and angles. Everything's mathematically equated. So you can dissect your own face, that the width of your eyes and the width of the distance of your eyes is in relation to the width of your nose and the width of your nostrils, which is in mathematical relation to the width of your teeth and the length of your teeth. So everything is golden proportioned, and the teeth are themselves. And VITA has taken and endeavored to make everything golden proportioned, because our heads are golden proportioned. And this is new trending and theory. There's one thing I want to be clear with, and I certainly don't mince words, and I'm often controversial when I speak, because I challenge the textbook in quotations and what we do and what we've been doing. And one of the contentious things or controversial things I'm going to say right now is again, it's not 1950s anymore. It's not the 40s anymore. And 20 and 30 and 10 and functional denture teeth, they're all designed from theories and philosophies that are back from the 50s and 40s. It's not that anymore. It's time to move forward and stop using teeth from that mindset in that era. It's time to move forward. And that's what I've noticed. And the benefit to me is that especially on the product here with the VITA Excel and Lingoform, is that it's newer theory and trending theory, and it's letting me and allowing me to be more adaptive to the patient, whereas other teeth can't. And I've left them go, and I've left them go away, because I'm not living in the 50s anymore, and I'm using teeth that allow me to be more flexible to the patient's needs. It's not cookie cutter anymore, and it's more not that cookie cutter type of approach and cookie cutter denture that I started building. It's now very expressive to the patient. So that's, again, just everything is golden proportioned, so that the dimensions of the teeth, everything's all kind of golden proportioned against each other by math. So I hate to say it, but should have paid more attention in math class in high school. But here we are, everything's math, and I'm learning to appreciate the golden proportion rules now in denture design. So we have to always ask ourselves, what does the patient want? And then, of course, should we change it? So a couple things quickly. VITA teeth have freedom and centric. By definition, that's the flat area in the central fossa of the lower, in which the upper opposing cusp comes into contact and permits a degree of freedom, which means when you hold the teeth together, they work in balance against each other, but there's also a little bit of play in freedom. They're not locked together. They're one of the only denture teeth on the planet that has this capability. We forgot about this. So 20, 30, 10 functional and 0-degree teeth do not have freedom in Centric. They are locked together. And a little sample that we can do on our own is just holding our teeth together in Centric. And I want you to gently wiggle your teeth together. Don't go eccentric movements. Don't move your jaw out and start going up the cuspal rise of the teeth. You should be able to wiggle them strictly in Centric. And that is wiggle. And everything has a wiggle to it. And that's the wagon seal wiggle, that the teeth have a little bit of freedom in them. And freedom, everyone, is good. So in your office, say it nice and proud. Freedom is good. We forgot about this. We forgot about freedom. And this is going to play really well into a class 2 setup. We can't have denture teeth that are locked together and non-adaptable. We need to be able to adapt the teeth so that they can adapt to the patient. And that's why this is important. The other thing that happens is that what I've noticed in certainly my journey has been the mother of all problems has been the hit and slide. You have to remember, patients cannot feel their denture teeth. There's no nerve to the tooth like there is on a natural tooth. So when you ask a denture patient to close or touch or bite and their teeth come together, Mark, you dummy, they can't feel their teeth touch. There's no nerve there. There's no feeling there. So they can't feel a hit and slide. And a hit and slide is where it hits the guiding plate and slides into position. You have to appreciate this could be the width of a human hair or the discrepancy of a human hair. They can't feel that. And then that is what causes the problems for us. It causes the shift or the wiggle or the damage. We expect a patient to accurately find Centric each and every time when they can't feel their teeth touch. And now most of it is going into senior citizens that have a degraded neuromuscular system or on medications. And as we age, our neuromuscular system and how the muscles fire become less accurate. And yet we expect that. And when we set up denture teeth on an articulator, we pinpoint Centric and everything is precise on an articulator, and then wonder why we have troubles in the mouth afterwards. So we expect somebody to be able to bullseye Landcentric on a tooth. This is not possible. And that was a big thing for me to understand was, geez, Mark, it worked good on the articulator, and I'd remount it on the articulator, and I would do everything on the articulator, yet the patient still is complaining that they have trouble doing that and they can't chew, or it's not working, or it's tipping. And then I came up with the good old excuses. Well, it's just a denture. But then my OCD took over and I started to question it. And so began again the journey that I'm sharing with you today. So it's not possible for a patient to do this every time. There's no nerve to the teeth, yet we design it and set it up like there is. And it's not possible for especially for a senior citizen to reproduce Centric. So when you don't do that, there's a hit and slide and the bite's locked in, and then that's what causes the shimmy, and then that's what causes the denture base to move on the gum, which lets in food, or causes that to cause the torque, which causes the break, or that shimmy or that movement now, as by showing of the horizontal red arrows, that's what causes the denture to move, and then that causes friction. Friction causes heat. Heat causes the denture sore. So these are things that the occlusion actually plays a big role in. So this photograph is a picture of VITA teeth. The green dots is what I call the freedom cusps. That's what we want. Those are the sort of the holding cusps or the shearing cusps to hold food onto the lower bottom teeth. The lower bottom teeth are responsible for bringing the food up like a bowl to get crushed against the upper lingual cusps that are now coated in red. So the red are the cutter cusps for lingualized occlusion, and then the black dots are sort of the bowl and the central fossa where the opposing cusp sits into. So we can set up lingualized occlusion, but it doesn't look lingualized. We actually can set it up, but it looks more like what we're standard used to, but it's going to be a mortal and pestle approach where 10, 20, 30, 33 degree, etc. functional teeth They're all milling teeth. So there's contact from the buccal to the lingual and the mesial to the distal through the whole tooth, where here we just have that red dot cusp touching into the fossa of the lower. These are more mortal and pestle. So this functions is going to be more efficient. And I have to tell you, I do not get the complaint anymore of I can't eat lettuce. That was a big one for me when I left school. And again, for the first 5-10 years of people complaining they had trouble eating lettuce. And now I've eliminated that problem with these teeth because I've realized that these are mortal and pestle, whereas other ones, all the other denture teeth on the market are milling teeth. So this has worked well. And so what does that look like on an articulator? That's this. So you can see that there's a little bit of wiggle in Centric, and now we do the standard working and balancing. And I shifted the buccal cusp of the upper out of the way just to facilitate. You can see the lingual. And now there's a little bit of wiggle in there from, again, the freedom in Centric. It comes out of the factory with about 1 millimeter of wiggle, okay? 1 millimeter of freedom. There you go. So that's kind of what it looks like on an articulator. So let's talk about a chew cycle, because that's going to influence our class 2 setup as well. So what's a chew cycle is, a chew cycle is the arc of the lower mandible when someone eats. So let's look at this video. This is of natural occlusion. Now watch the jaw. You see how it's not going straight up and down? It's coming in at an arc and angle. So it's like a teardrop. And the patient's chewing apple, and the apple is usually all on the posterior teeth, mostly on the molars and the second molars. The lower holds the food, brings it up to the upper to get crushed by the lingual cusps of the upper teeth, and the lower's there to hold the food up. The buccal cusp of the upper is a shear cusp to help, again, hold the food, and the lower lingual cusp is the shear cusp to also hold the food on the chewing line to get crushed. So this is important for us. And in this video, you can actually see now, this is really, look at the rotation here. It's a little bit oval. You can actually see the freedom where they touch together, slide over, and then open. It's really dynamic here that you can see the freedom in Centric. And the teeth are designed with that motion in mind. And that's how natural occlusion is. And then that's how someone's going to chew with a denture. This last video I just want to show you quickly is look at the cycle of this person. What do you see different? See how it's more vertical? It's not as teardrop as the other person. See? So now you can, the teeth function within a chew cycle. So that's the big thing here, is that teeth function within a chew cycle. And we don't pay attention to that. We didn't learn to diagnose that or pay attention to that in school, and no one taught us. And I'm here to challenge that now and say the teeth have to work within that chew cycle. And we missed that on an articulator. So how do we identify a chew cycle? Well, some of the clinical things that we do is we say 66, we have the patient count from 1 to 10, 60 to 70, etc. And we would look at the aesthetics of the tooth and how it looks inside their mouth and behind lips. Well, now I'm training my eye to take a look and see their jaw posture. So this patient's going to say 66, but now watch their jaw move. You see it posture to her left? It cycles to her left. So I'm looking and training my eye. You can see it there. Look at that. And so it didn't come out straight. We look for protrusive on an articulator. We come straight out. Look, her protrusive didn't come straight out. And that's where you run into the trouble of teeth chipping and things that aren't working because we didn't set the teeth right. So I want to be clear here, and this is where Jim's going to stand up and do the hula. This is when you chip teeth and you chip anterior teeth, it is not the manufacturer's fault. Contentious, yes, yeah, I'm controversial. It's not, it's on me. I had to realize I'm the one that set the teeth. I set them in the wrong spot because I thought protrusive on the articulator was what I was supposed to do until I started to look at chew cycles of patients and go, well, wait a minute, it's not coming out straight, yet I set it straight. Well, no kidding, it's chipping because now it's hitting on the left side. So now I'm learning to identify a chew cycle of a patient. And even if you're a dental technician, this is something that you can take to your doctor, especially on the next, again, stressful trouble case that you have come in and everyone's a little tense on it. You can say, look, I need you to take a video for me, and then we can start and open and have that conversation about what's a chew cycle and then what am I going to need to do to make that correction. So take a look at this patient. Look at her jaw move. You see that? Now, days of the week and months of the year also cover the phonetics of every language. The phonetics are the A, E, I, O, U's, and that's what moves the mandible and the jaw. So it postures forward, it postures from side to side, etc., to be able to pronounce those fundamental building blocks of language. The phonetics of a language are covered in the days of the week and the months of the year of every language. So you have to have your patients say days of the week, months of the year in English, and then their mother tongue if they have one, so that then you can see and identify the jaw move. So that's really important to help identify it. This one, again, I colored the teeth on the bottom just so you can see. You can see her jaw posture. Comes out to the left a little bit, or actually her right even a little bit. So these are things that you can start to look for. So this is a complete upper denture to a cast frame lower free end partial denture. Look at him chew. Is he chewing up and down? No. He's chewing at an angle. Look at that. That's programmed in us. That's subconscious. That chew cycle exists. That thing runs. It doesn't matter. It's always there. Okay? Yet, how did we set the teeth on an articulator? Not to mimic that, that's for sure. And that's what I'm going to challenge you now today, even in a class 2, is to start setting it and functioning like this, and I'll show you. But I wanted to show you some why before I show you how. So a chew cycle influences tooth interaction. You have to modify the teeth to the cycle, regardless of whether you're doing traditional or digital. And a chew cycle is defined by flat, oval, circular, ovoid, or teardrop, or a combination. And so now I'm learning to identify those cycles and to, again, set teeth within them. That's going to eliminate the hit and slide. And that's what I'm trying to get after here, is that I don't need teeth that are locked together because they're built to have hit and slide. Okay? So I want you to keep this in mind. When you set 20-degree teeth, you're setting 20-degree teeth to have working and balancing contact. So as the right side comes up and goes working, the left side has to do balance. And so it's the principle is that everything's touching and functioning at the same time on an articulator. Now that you've seen a few videos of people chewing, do you think that that's actually happening in their mouth? Because now you're asking someone that has food now between their teeth to actually at the same time land working and balancing contacts at the exact same time in a chew cycle. That's not going to happen with 20, 30, 33, 10-degree teeth. Sorry, it doesn't happen. And we expected it to, but that's why it doesn't work, because you've got food in the way. And now the teeth have to cut through the food. Yet we designed it that right and left side has to contact at the exact same time for it to work in balance. That's wrong. It has to be mortal and pestle. You have to have that little helicopter pad to land in, and you don't want the hit and slide. So this is what it looks like on an articulator. We move the articulator like this. This is our standard motion that we were taught. You take it and you do working and balancing contacts. So this is me, and I'm doing standard working and balancing contacts, okay? And this is how we would typically move an articulator. And I'm telling you, I don't do this anymore. This is what I do. I start taking an articulator and I'm doing a chew cycle, and I'm watching how the teeth are going, and I'm checking the hit and slides. And as I'm moving the articulator, you can see the cusp is doing different things within the fossa. That's what I want, because then I can adjust the teeth and adjust them without damaging them to facilitate how they function within someone's chew cycle that I identified clinically, and that I'm asking you to ask your dentist clinically now, because this is about creating efficiencies. Efficiencies help everybody. They help the doctor, they help you as a technician, or you as a denturist, or you as a prosthodontist that are listening. or you as a doctor that's listening, efficiencies are important so that the team functions efficiently. And the entire dental team that's there to service and help that patient that trusts us. So again, this is a Protar articulator. I've done it on every articulator, hinge articulators, it doesn't matter. You can move an articulator and facilitate a chew cycle. And this is what it looks like up close now, is the cusp coming in, and I'm just trying to control the hit and slide. And so now, depending on how I move the articulator, you can see sometimes that there's no hit and slide, sometimes there can be a little bit of one, and that's what I would go in and adjust. So that's just what it looks like up close. And that's what I want. I want that mortar and pestle, smash the lettuce, smash the food. Okay? So I want to just talk clinically a little bit. The average adjustment rate for dentures is 2 to 5 times. So I can expect it a full or a complete upper and lower denture patient back in my office 2 to 5 times traditionally for an adjustment. So what does that mean? Well, most adjustments are 20 to 30 minutes in length. So let's look at the math. So say a denturist or a doctor charges $2,600 for denture. Say by estimate the lab fee was $700. That left a estimated subtotal of profit for the dental office or the denture clinic at $1,900. If your office overhead was running at about 75%, so overhead would mean rent, wages, insurance, materials to run the office, that left you a profit or the office profit of $475. Now, if 2 adjustments come in and at a billing rate of $100 an hour, so if your doctor or myself as a denturist charges about $100 an hour on 2 adjustments, that only left a profit of $275 for the office or for the business. And it's actually less if you consider you have to pay to clean up the room, and it's less because you're not making money in an adjustment. And so it's downtime. So it's actually more costly than that. 4 adjustments leaves a profit of 75 bucks. So boy, do you lose money in a hurry. So if we can control an adjustment, it's a big deal. 1 adjustment a day, everyone, at 30 minutes is 2.5 hours a week. That's 10 hours a month that you're working for free. And you got to figure 30 minutes. Why? Because you got to seat the patient, get the patient in, you're tying up the chair, then the doctor or the denturist has to come in, find out the problem, go fix the problem, chart it, dismiss the patient, clean the room. Sorry, that's more than 5 minutes. So it's about a 30-minute span. And so this is a big deal. If I can save you 30 minutes a day, all of a sudden, holy man, you get to eat your lunch today. Because as a denturist, and again, chatting with people globally, I have a good idea of how many adjustments are done in a day and in a week in an average denture clinic or a denture practice. You guys, it's a big deal. Denture clinics, globally are running anywhere from 20 to 100 adjustments a month, depending on how busy the practice is. And you have to keep in mind that if we can save and cut that adjustment rate down to 0 to 1 consistently, that's a big deal. And that is, again, a big deal on your stress, and that's a big deal on your time and efficiencies. And typically what a denture clinic does is they just tell their secretary to put the adjustments in over lunch. If the adjustments are, if you hold 1 adjustment in the morning and 1 in the afternoon, and someone else phones in, well, you have to bring them in on your lunch hour. And so then you're eating on the fly. Well, do that week in, week out, year in, year out. It wears on you. We have to take control of this. We don't talk about this. So count up the adjustment rate. Call the secretary of your dental office, of one of your best denture clients, and ask them how many denture adjustments did they do on the last few cases you sent them. It's surprising. And if you can reduce that adjustment rate, it's a big deal. Remember, the rule of thumb is 1 missed dental appointment requires 2 or more to recuperate that lost revenue. It's the same as an adjustment. you are tying up the chair and you're not making money. So if you can be more efficient in the lab for that doctor, they're going to stay with you and support your business. If you can take control of this as a denturist or as a doctor in your denture practice, this is a big deal for your chair time as well. Okay. So Freedom and Centric helps address our common problems that we face every day dealing with dentures, because remember, the patient can't feel the teeth touch. So I want to talk quickly about professional happiness and Freedom and Centric. A lot about what I spoke to now and talk to you about chew cycles and a little bit about the teeth before I show you how to set them. The World Health Organization listed burnout in its 2019 classification of disease. So burnout is now a disease. It's characterized as feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism. Guess what? The cynicism, oh, that patient's just crazy. Oh, she drives me nuts. That's her unrealistic expectations. But we use that cynicism to justify that patient's back in our office on the 6th or 7th time. And those situations exist, but we don't want those to be the norm. We want to reduce that, and we can. And so you have reduced professional efficiency and a disrupted sleep pattern. If you're recognizing that, everyone, you're suffering from burnout. We don't talk about this in our industry, and now I'm going to, because this is important. You do this day after day, week after week, month after month, year after year, we burn out. We have a high rate of burnout in our industry. A major sign of burnout is if you go on a holiday, even a long weekend, and come back and after a few days of work, you feel like you've never had that holiday. Well, guess what? You're suffering from burnout. So what can we do to manage that? And I'm sure some of you are snickering, and this is, again, globally when I lecture to this. You're suffering from burnout. So we can control what we can. And that's, again, using teeth that are flexible to us and our needs, to mimic that chew cycle to get after so that it fits better in the patient. That's important. So these repetitive problems cause us stress, and I'm offering you an opportunity to help reduce that and manage that burnout rate that you have, regardless if you're a technician or a denture professional clinically. This is important. I'm asking you to try the VITA line and the Lingualize teeth that I'm going to show you today, because it saves me grief. I'm happier in my professional job because my adjustment rate is consistently 0 to 1. Yes, I have the odd patient where it's higher, but that's realistic. You're always going to have that 1 or 2 patients that just need more of you, and they're going to be back more. But consistently, I'm 0 to 1. So we want to further our relationship with you, and ergo that patient that places their trust in you. And these are the representative lists. So again, this is on the video. You can pause this and then find your rep in the area. So these are the VITA reps that are there to help and support you, as well as myself. And I am available to you as well. And Jim will be putting up my contact information at the end of the show so that you can contact me directly as well, because I'm here to help you and I want to help you. So we're here to support each other in our industry. So I'm going to switch screens here, and I am going to jump to my camera. And Jim, I'm just going to ask you to make sure that the picture is up and running.
Yes, it's online. Got it.
Awesome. I love technology when it works. Okay, so remember, let's look at this. So I want you to pretend these are 20-degree teeth. 20-degree teeth operate that everything has to touch, come through, land, and touch, and it's doing it bilaterally. So both have to do this at the same time, touch at the same time, in the same manner in someone's mouth for it to work. We do it on an articulator, yeah, but now I'm talking someone's mouth. It's impossible, not going to happen. And that's why I banged my head on that wall over there for so long, going, what am I missing here? Because I'd remount it and it would always have that same result. So this is the freedom right there. This is the main cusp that's going to come down, and this is to bring the food up to get hammered. And then I want to watch the guiding planes. So the guiding planes are here. I'm looking for hits and slides, okay? I don't want it to hit and slide into position. So now I'm coming up with a chew cycle. So do they have a more horizontal chew cycle? Then yeah, I'm going to get more opportunity or more chance of a hit and slide. So I can go into the VITA Teeth and adjust the guiding planes to allow this thing to function more horizontally, yet not disturb the main power cusp and the bowl that's holding the food. And that way it can function within that patient's chew cycle and have less chance of a hit and slide. Because remember, a hit and slide, it can be the width of a human hair, but we all know a width of a human hair is like 6 miles in the mouth. The buccal cusp here is the shear cusp, then the shear cusp. So they're there to help hold the food and kind of keep it in this zone for this system to keep mashing and pulverizing the food. Okay, so you can set up what's lingualized occlusion, yet you don't have to have that buccal cusp tipped up all the way so that it would look unsightly. You can supply this to your doctor and still have a nice buccal overlap, and patient can't tell. But this is a lingualized occlusion without it looking like lingualized occlusion. That's the beauty of this. And that's the beauty of now identifying a chew cycle, and if it's more horizontal. And then I'm going to make that adjustment in one's mouth. So I'm going to switch. Okay, so now we have some models, and we're going to slowly start to get to set the teeth here. So we're going to do a live demo. So that means, yes, I'm actually going to work today. So what I did was I circled the incisive papilla in black ink so that it shows up a little bit better on the video camera. And I also circled the long branch rugae. So these are the first rugaes that are after the incisive papilla. And then I draw a dot. And so the long branch rugae always points to where the canine goes or the cuspid goes. So that's, again, I come back to the golden proportion rule. That's golden proportion. So when I start setting teeth, my cuspids should be at the end of that long branch rugae pointing. If that's the case, then I know I'm golden proportioned for this patient on this model, on this person. That means then that the teeth are going to fall in the correct position of their face. Okay, so hi. So that's important that the canines follow here, right here on the canine eminence, pushing out, because that's right where my nose is, and everything again is mathematically equated. And so by following this model analysis technique, we're making sure that the teeth, that the teeth are coming in at the right position. So this is one of the most important model analysis marks that I make, is not only the incisive papilla, is the long branch rugae, because that points to me where the cuspids go. So typically what we're going to do is we're going to be setting the anterior teeth 6 to 9 millimeters ahead of the center of the incisive papilla. So why 6 to 9? Well, 7 to 9. Pardon me. Why did I say 6? It's usually 7 to 9 millimeters ahead. So 7 puts us on the wet and dry line of the lower lip, and it usually is right on the border of the wet and dry line of the lower lip. 9 millimeters puts us anterior, just slightly anterior of the wet and dry line of the lower lip. The reason why you would ever want to do 9 is that if the patient is demanding a little bit more support and denture support, we can go up to 9 without it looking like Bucky Beaver, because you're just ahead of the wet and dry line of the lip, but it's enough that it can help with that support of the upper lip, and especially the red of the lip, and pushing out the red portion of the lip. So it's a nice little trick. So what model analysis does is it sort of, again, gives us that golden proportion rule that exists here in the model that we can transpose to what the setup will do, and then how this is going to work in someone's golden proportion skull. All right, one moment, please. I am going to heat up some wax. And you guys get to watch me work today. Now, isn't that a treat? So when I do a setup, I typically cut out this anterior region so that you can see the model. And then that way, that helps me reference the lines that I need to follow when I set teeth. So this is a class 2. So you can see totally class 2. So again, I'm looking to set the teeth about 7 to 9 millimeters ahead of the papilla based on the individual needs of that patient. So if it's fairly standard, I'm looking to basically just go 7 millimeters. So it's 7 millimeters to this incisal edge. So let me just color that for you in black so you can see it a little bit better. And now I'm just following that approximately 7 millimeters ahead on that incisal edge. Okay, so that's kind of where I'm going for. And then also standard would be about 22 millimeters, whoops, can't see, 22 millimeters down from the sulcus if you have no other information. Okay, so that's kind of gives me a little bit of a starting reference point for someone. So that's pretty standard. So what I'd like to do for you is just set up one quadrant here, because now we can talk about the idiosyncrasies of a class 2 setup. Okay, so I've set the lateral, and now I'm going to set the cuspid. And then again, what am I looking for when I set the cuspid? Is I am looking to see if the long branch rugae is pointing towards the cuspid. So let's make sure that it is. So I'm going to take a little bit of this away. Just to, again, so I apologize, things are going to move a little bit, but I'm doing that specifically just to exasperate the point here of when you set the teeth and you come up, that long branch rugae should be pointing towards the center-ish of that cuspid. Now your tolerance zone is about 1 millimeter, a little bit each way, but this tells me then that as I'm circling through and this rugae is pointing towards this cuspid, that's the right size of teeth at the right arc and angulation, so that this is golden proportioned now for this patient. And that's what's really important, is that golden proportion rule, because remember, everything operates within that golden proportion rule of that patient, which means all the arcs and angles and the function and that chew cycle follows that. Okay, so what we're going to do is, again, we set the first bicuspid. So I'm going to start here for everyone. So VITA teeth are very flexible. You can set all the uppers first, or you can set all the lowers first. You can set them to a flat plane. You can set them to a curved 20-degree template. You can set them to a customized template. It doesn't matter. It's all going to work because, again, these teeth are not locked in. They have that flexibility and freedom. So what I'm looking for, again, is just this triangle that's developing here between the distal cusp, pardon me, and the mesial cusp here of the premolar. So usually on class 2s, and let me just flip to this side, Usually on class 2s, you can already start to see there's a discrepancy here to say, well, geez, depending on how class 2 this is, wow, Mark, I'm going to be hanging my lower out in midair. So what the model analysis does is it helps us see where things should go from that golden proportion rule for that patient. And these black dots that you see down here, the black dot for me is, again, where the first premolar typically goes, and that's at the end of the buccal frenum. So wherever that buccal frenum lies is usually where the first premolar lies. So I'm knowing that I'm with this setup a little bit anterior to that position, given that this is a class 2, but it's an exaggerated class 2 for the demo today, because I wanted to take things and just make them a little bit more aggressive so that you can see it on the video better or on the screen better, versus in a live course where we can have a little bit, we can have a little bit less. It's just what I've learned now doing webinars is that you have to over exaggerate a little bit so people can see the fine point. But what I want to do now is to show you some of these cool things with these teeth. So let's set the lower, and you're going to notice I've got different color teeth here so that they help show up a little bit better on the video. So typically speaking, I'm going to be setting that first, okay, the first buy. Now here's some of the subtleties of this. If I set that first buy in what we would deem as proper occlusion, proper meaning cusp to fossa occlusion. So this is what we would want to see. I would want to see that tooth properly interdigitating against the upper. But if I look at it head on, what are you seeing because of the class 2 is that I'm kind of floating this tooth a little bit, and I'm a little bit off the ridge, but I'm more worried because class 2s typically can have a tighter jawline and a tighter lip line, meaning that their lips are tighter here because of the structure and the way the muscle lines on the curvature is that I'm going to run the problem of the cheek hitting the denture because it's a little bit thick, and it's going to be popping it out when they yawn, when they laugh, or even during the chew cycle. So this allows me freedom. So let me explain this. Typically, if this was a 20-degree tooth or a 30-degree tooth, etc., I'd have to have it interdigitate like this, or it wouldn't work. Now I want you to draw back to the chew cycle and remember where was all the contact? Well, it was in the molar area. So the first molar, second molar specific area. So now what I can do with this is I can take this tooth and I can actually push it in lingually. Now, what did that just do? Well, I want to show this to you because this is pretty cool. So you'll notice this when I had the drawings of the teeth and where the cutter cusps are. And on lingualized occlusion, the first premolar, this is actually that hammer cusp. And the bowl is actually on the upper. Okay, and then it flips over, and then all of the lingual cusps are the ones doing the cutting and the lowers are doing the holding, but it's flipped on the first premolar or the first bicuspid only on lingualized occlusion. So what that looks like, and let me just put this aside so I can use the larger example here. And forgive me because this is a molar, but the point is this, okay? If I set this, then I was off the ridge, right? And you could see that. But what's happening now is I can take this tooth and I can move it in a little bit, which is what I've done. The reason why I can move it in is let's tip them the right way, Mark. Okay, so I can have it, but I can move it this way slightly. Why? Because I've got that 1 millimeter zone. So remember, this is my freedom out of the factory. So I can take this tooth, remember how it wiggles side to side? Well, now I can go on this side of that helicopter pad. So what that did was that moved it over 0.5 of a millimeter closer to the ridge. And then all I have to do now is adjust the guiding planes a little bit, and I can even move it more. So this tooth can stay where it is for aesthetics, so it doesn't look all shoved in. I can leave that first, for example, premolar in, but now I can move the lower in to accommodate. I can't do that with other teeth because then I'll be cutting them and I'll be damaging them too much. You can do that with the freedom teeth without damaging them. So now I can take that lower and I can push it in so that then this red cutter cusp that's at the bottom of your screen there is coming more towards the inside of that upper bowl that holds it. So all I've done is I've just skirted the tooth over a little bit, and I haven't even cut anything yet. But I can do that because I have the freedom aspect built within the teeth. So then that lets me do that. Now what that did was that increased the overbite or the overjet of the tooth a little bit, okay? But again, behind lips, what you're gonna see is the nice arc of the tooth and the tooth coming through. So you get the smile line and the little triangle by the cheek. So the upper will look good. Because the lower jaw is smaller, it's a little bit more in, so it's compacting itself. So it's gonna fit more within their jawline and their facial features. Yet I still have contact here and proper contact of that cusp coming into the fossa. So that's a real blessing and a real draw for me using the teeth and using freedom teeth, is that it's allowing me that flexibility. So you heard me say that earlier about customizing and flexibility and freedom and these types of comments. This is what it looks like in action. So now we can set some more teeth. So let's play with this a little bit. So that was the first thing I wanted to show you, was just a little bit of that flexibility and freedom that we have that can happen. The other thing that we typically see with a class 2 case is we don't have a lot of space. So what that means is we typically are having to drop some sort of a tooth on the bottom, yet we can have the full complement of teeth on the top. And so sometimes we run into problems because it's hard to line things up appropriately so that the right tooth is over its proper antagonist. And that's where, again, freedom teeth allow for that flexibility, that we have way more flexibility that if we can't make it work, it's still going to work. So let me explain what that means as I quickly set some teeth to show what the example is. So allow me a minute, I need to heat some wax. So my dear colleagues, what I did was a rethink of treatment care for a patient over my humble time now in my profession. And the rethink is challenge what you think you know and what you think you can believe and what you think you believe, and then change it. Because now I'm building dentures that I never thought would work and that I never thought could work, because I'm able to use product that allows me to adapt to someone. Because again, it's about baby, you were born this way. And that's allowing me now greater flexibility and satisfaction in doing my job and caring for someone. It was a total rethink on how we were taught. So as I develop this to show this to you, I'd like to really point out the benefits of what freedom and centric and using what I call freedom teeth really can do for you. Because it's aesthetically going to look okay. We're aesthetically going to keep the smile line and the triangle on the cheeks. All these things are going to look there, but it's going to function within the chew cycle of the patient. So typically we're short on the bottom and that we can only say put in 3 posterior teeth. I will always drop the second bicuspid if I have to drop a tooth in favor of a larger second molar and molar because those have a larger table to bring the food up to get crushed. Sometimes though, we need to put teeth further back on the upper to keep the cheeks puffed. So a lot of times we run into some issues. So let me explore some what ifs with you, or some possibilities, or some shouldas. Okay. So let's look at option 1. Option 1 is that I can set a molar over a molar. So a first molar over a first molar. That's option 1. So what happens is this lingual, so the mesiolingual cusp here rests into the fossa, right there of the lower molar. Yet, when you look, I can, and let me just kind of angle it there for you. There you go. You still have some overlap here, so it's not knuckle tight. And when you look, it's not knuckle tight, because remember, I need somewhere for the food to stay. Yet, it's a lingualized occlusion, but it doesn't necessarily look like a lingualized occlusion. So it doesn't look like one, but it's going to act like one because that cusp in red is going to be smashing the food that's being held in this bowl. So that's option 1. So option 1 would be to do that, but now I'm going to be having to add some teeth on in the back. Let's say, for example, that option doesn't work. So we run into an issue that you say, well, Mark, I need to add a second molar in here. So now I'm trying to put a second molar over top of a first molar. So let's do that. So I've got a second molar coming in here, and it's going to go over top of the first molar. Why can't I do that? Because look what it just let me do. That lingual cusp went into the fossa of the lower. So that's this cusp. So that red cusp went into the fossa of the lower. So now I can put in even another second molar. So here's the thing. Sometimes it's not the ideal, but what I'm doing is I'm putting a hammer into a bowl. I'm putting a cusp into the lower corresponding fossa. Now this is a smaller cusp. It's smaller than the first molar, so it's a little bit less efficient because it's smaller, but it's still a cusp in the lower fossa. That doesn't matter. Sometimes, again, it may not be the ideal, but it's going to work. And it's going to work because it still follows the freedom. It still has freedom in centric. So now what we can do is I can actually add in a second. So we can, again, show you the what if. So let's put in another one. So now I've done another second premolar, had it come in. Look, it just nestles right into the fossa. That's the beauty of these teeth. I honestly don't care what cusp you put in what fossa, because it works. And now, from that perspective, behind lips, what does the patient see? The patient sees the nice curvature. They see a little bit of the emergence profile. You're going to have the little triangle here. But sure, it looks like this, but that doesn't matter. Patient doesn't see that side. They see this. And clinically, we see this, which looks good. Okay, this is in, so it's not going to push on the lip. So I'm on the inside part of the fossa on that corresponding tooth. Good. So it allowed me that flexibility. I didn't have to grind anything yet. And now I've got lingual cusps in fossas here to hammer the food and crush it. So I can take whatever and put it in there. So let's take this out. And now I'm going to throw for fun. Let's show you what we can do. I can put in a second molar. So let's put in a second molar to show you. The second molar sits in there too. So I've got a second molar straddling a first molar and a second molar on the bottom. Still works because that cusp still goes into fosses right there. Excuse me, still goes into fosses right there. It doesn't matter. So on a class 2, where we have different things, like there's different classes of class 2. So I can show you all these different arrangements. And I'm showing that to you because, of course, what I do here clinically, or what I do here in the lab for you today in the demonstration mode, you may pick up your next class 2 and it's a lot different. But what I'm showing you is don't be scared, because now you can put whatever tooth over whatever tooth, so long as you're keeping in mind that you are putting this fossa into these bowls. And it doesn't matter because there's a bowl, they're all over the place. Okay? And that's how it was designed. And that's what I had to show and even highlight to VITA themselves about the beauty of these teeth. Because now we have this setup. So I've got this kind of quirky setup, and it may not look good to you and I on the workbench, but remember, behind lips, that thing looks normal. It's going to look normal for that patient and that person, yet it's going to function and chew. So now from a chew cycle perspective, I'm going to open the articulator. So remember I said, I don't want to do this. I don't want to do this anymore. I don't check like this. Because remember now I showed you those videos. Any of those chew videos that I just showed you, does anyone do anything remotely like that? No, they don't. So again, controversial Mark says, no, stop doing that. I want you to do this and start moving your articulator. I don't care what articulator it is. You can move it like this. Sure, you might have to grab it and you gotta work it a little bit, but I want you to start to now move the tooth, okay? And move things. And then what you're looking for is now you're looking to see how the teeth are functioning within that chew cycle. So allow me a moment. I need to lute everything down and I'll show you how to calibrate it. So what I wanted to show you today is one, identify burnout and what's burnout, and burnout caused by repetitive problems that we face building dentures for patients. And it's hard on us because it's a repetitive issue of the patient complaining or the doctor complaining on behalf of the patient to say these things are repetitively happening, how do we fix them? Okay. The other thing I wanted to talk about now was how do we solve that? So I wanted to introduce you to, again, the freedom concept and freedom in movement. So the freedom in centric. What does that mean? That means you have that little bit of wiggle room. You have that helicopter pad to land in. Then I wanted to introduce you to a chew cycle to say, look, everyone chews in a certain manner. Just like you have a fingerprint, just like you have a retinal scan, you have a chew cycle. And that chew cycle is unique to you. And you function within that chew cycle. And then I wanted to introduce you to how do you manipulate and move an articulator to mimic that chew cycle. And now try to identify that chew cycle. So again, I showed you some ways and some innovative ways to how to identify that chew cycle so that you can start to do that in the lab. Now, if you can't get that information from your doctor or from the lab slip, then I want you to use your deductive reasoning. Your deductive reasoning is if you have any information. So how old is the patient? The older they are, usually the less accurate the muscle structure is, and the less accurate they're going to be with their chewing. So that's first and foremost. The second thing is if you have that information, that helps you. If you get no information and you have nothing about that patient other than build teeth, please, then I want you to always err on the side of caution. Erring on the side of caution is think they need more wiggle room and that they have a flatter chew cycle than anything. It's okay to overestimate than it is to underestimate. Okay, that would be my rationale and my train of thought on that. I'd rather overdo it than under. So forgive me as I just take a minute to clean the teeth off to show you now the calibration aspects that I do. So I just want to take rid of the marks that have shown themselves on the teeth as best as I can here. So thank you for your patience. Okay, I'm not going to get that one off. So in the lab, I use these pens. So I use Statler non-permanent, made in Germany. Woo! Okay, so I use that, or you can use Sharpie non-permanent. I don't use articulating paper, and the reason why I don't, what? I do. Did he just say he doesn't use articulating? I did. I don't use articulating paper, and regardless of its kind or thickness or anything, I stopped using it because the minute you do this and you start to close it in around the teeth, it bends. So what happens is when you have this, and now when I stick paper, between that, okay, and I say I stick paper between this and I bite, the paper is going to bend and mark itself, and you do get erroneous readings. When you follow what I'm going to show you now from a calibration perspective, you do not get the erroneous readings. So remember, you're going to color the main cutter cusps, whichever ones you really ended up using, which means however the setup goes. So we're going to follow this approach where I did this mishmash of teeth. And the first thing that I'm going to check is your centric contacts. So that's the quick, just straight centric. And then I'm going to do this. So I'm going to bring this up so you can see. And let me hit focus. All right. And let me point to you. So it's going to hard to be seen on the screen because now these marks are very finite. But there's going to be a little red mark here, there's one here, and there's one here. So that's this little tripod mark is from this tooth right here. So this sucker, that cusp, is nestling into that central fossa right there. And then this cusp here, remember, is nestling right in here. So it's going to be hard to see on the video because now these marks are going to be very finite. And we're used to seeing with articulating paper these big blotches of marks. No, this is finite because remember, we deal with the width of a human hair. If it's out the width of a human hair, it's like it's 6 miles. I don't need this big mark, I don't need that. I color this to show me the very, very, very finite marks that you get here. And now what I'm going to do is I'm going to take the articulator and I'm going to open it and I'm going to do a chew cycle. So I'm going to follow a chew cycle. And what I'm going to do now is I'm going to look and see where are the marks. So again, I'm going to hold it up. And again, I'm going to apologize because I can show this to you way better in person than I can on a camera. But you're going to see that there's some little bit of marks right here on the guiding plane, which meant that cusp hit and slid in with that facilitated chew cycle that I just did. So now I either move the tooth in wax, or I take a very fine burr or rubber wheel and I take care of that little guiding plane. And then what that does is that lets this function without that interference. Okay, so that's the idea behind it. So what have I done? We have a class 2, and now I'm showing you, because you have different class 2s and different options, we can put different teeth in. So different teeth with the same principle, though. The principle is there's a cusp that goes into a fossa. And so it doesn't matter what teeth you put in. What matters is that I'm trying to put a cusp into a fossa. So now I've grabbed an upper first molar and I've gone back in and touched it up there so that it's in. And now I can do a second upper molar. And now I can facilitate what we would deem to be a little bit more of a standard, a tooth arrangement. And now it's the same thing where I would go in and I would color these lingual cusps that are the cutters. But remember, the cutter on the bottom is always on the lower first premolar. And then I would do my centric tap, and then I would unlock the articulator. And again, regardless of your articulator, do a chew cycle, left and right. So some kind of a chew cycle. And then I am looking for, look at that, touches on the guiding planes. So there's one right there. See that? There's one right there. There's one right there. So again, hard to a little bit to see on the video, which I'm sorry, but they're there. And so then that was the hit and slide, where it hit and slide. So that was me doing this, and I caught a hit and slide where it hit and slid into position. So that's what those marks are here now, showing it to you on the real thing. So again, behind lips, okay, looks the same, yet now I have a little bit more of a traditional type of setup. But again, it's not locked together, but I still have, look, so as I hold from that angle, you can see I still have, just a minute there, I have to lock it. I still have overjet. So again, what you're going to see here is that there's little bits of freedom and gapping in there. So it's not knuckle tight. We're used to setting these teeth and looking at it knuckle tight. And I'm here to say, please stop doing that, everybody. Technicians, doctors, everyone that's listening, woot woot, stop doing that. Because here's the thing, if it's knuckle tight and it's this super tight contact, where do you think the food goes when they close in? The food gets pushed out because there's really very little space for the food to sit on here. So what happens is the food gets squished out and then it has to get put back on and then it gets squished out. This isn't efficient. It takes you more effort, twice the amount of effort to eat, in quotations, because you keep knocking the food off to just get put back on. You want to have these little bits of gaps in here so that the food stays on here to get brought up to here to get crushed. So from a class 2, what we notice now is depending on your space and your limitations, you can use different teeth to make this work. So I'll always start with the first premolar, and then it's whatever I need, whether it's only second premolars or whether I can put molars or even just second molars in. It doesn't matter. Just put them in, because again, behind the lip, all you're going to see is that emergence profile. The patient's going to be satisfied with it. But what you're achieving is the occlusion, and that occlusion within a chew cycle, and the occlusion to mince the food and to have it pulverized. Okay, next. How are we all doing out there? Are we having fun yet? Have I been controversial enough yet? Jim, this is where you pop up and go, has Mark been controversial as usual?
Mark is always controversial, so get your questions in now. Why, Mark? Why?
Yeah, exactly. Because I've had a long time to let my OCD out and figure this stuff out of challenging the system. And then again, finding a product that works with me and allows me to challenge it. Because this is all about me adapting to a patient. I'm just the conductor. I'm just there to make this work for the patient. Okay, the patient knows how to eat. Your first violinist knows how to play the violin. I don't have to teach you how to do that. I'm there just to see the vision through of how the music should be interpreted and played, in my opinion, as the conductor. And you're the violinist, so you just play your role, and I'm there to help you through it and get you through it. This patient knows how to eat. That's programmed. That's programmed in them already. There's a chew cycle here already. I'm not going to influence that chew cycle. It's there. I'm there to identify it and then work within it. And that was my rethink. When I said I rethought treatment planning, that was my rethink. My rethink was, wait a minute, don't do it just because. What does the patient need? So on a class 2, when you set anteriors now, this becomes the dodgy part and a little bit tricky, where you have to watch where the neck goes, because you have to watch where the sulcus is, because you want to make sure that this lip is usually going to be quite tight, and we don't have a lot of room in there typically. Okay, so it's kind of interesting on sometimes how this has to work. So what does that mean? Well, it's funny because sometimes I've set it just with 4 anterior teeth, and then this first premolar actually takes over the role of a canine. So we kind of have to be a little bit creative and flexible. The nice thing about the VITA teeth and the emergence profiles of the teeth is that you can get away with that sometimes. So I can get away with it when I have to push teeth into roles that they may not have been designed for. And that's what I wanted to show you, was I wanted to show you that I can set teeth and have them work in a design limit and a design zone that they weren't necessarily intended for originally. That doesn't matter, because what doesn't change is the freedom. Okay. What doesn't change is the chew cycle. So now stick lips on this thing. Okay. So if you're paying attention, I'm going to tip my hat at what I just did. So I've got a lateral, I have a central, lateral, and I put another central in. Okay. Now all I'm going to do actually is take a burr, and I can bevel this distal corner off a little bit so that it's just going to not have that squared off approach. And actually I can turn that into a cuspid in a big hurry, and it's going to work, because again, behind lips, the patient's not really going to see that. What they're going to just see are 6 anterior teeth there. And then again, I've got proper overbite and overjet, and I'm watching the sulcus and where the teeth are going. So I can just go in here and bevel that corner off. So if you allow me a minute, I'm just going to take this off because it's loose. And let me just grab a rubber wheel. And I took the corner off. So I overdid it a little bit just so that you can see it, but you can see now how I took that edge off. And now I'm going to come in there with lips. And what do you see? See, it looks a little bit less flat. So these are little things that you can do to identify and show yourself and modify things. So if you can set a full complement of lower anterior teeth in there and not have to do this, that's fine. What I like about the VITA teeth is that they're designed and have the principles designed that I can modify them and change them, and you don't see it. And they allow themselves to be manipulated and worked. So I've got the necks tucked in so that I'm not exceeding the zone limit here of the sulcus, because I know that orbicularis oris muscle, that lower lip muscle, is going to be really tight in here on a class 2, and I have that flexibility in here. So now the question lies with, well, Mark, are you doing 1-to-1 or 2-to-2 for overbite and overjet? Well, let me answer it this way. If I do 1-to-1, why 1-to-1? And how do I know that that patient's 1-to-1? How do I know? So when you went to school and they were teaching you, well, you should do, 1-to-1 or 2-to-2, and my response always is, why? How do you know it's 1-to-1 or 2-to-2? Well, that's what the textbook told me, or that's what my boss told me. Okay, but how do you know in that patient's mouth it's 1-to-1 or 2-to-2? So remember my comment. It is not the manufacturer's fault when anterior teeth chip or break. It is not their fault. What happened is that we set them in the wrong spot. Now, sometimes they break because you caught it on the wrong way on the wrong day. Because remember, there's no nerve on that tooth, so the central nervous system couldn't feel it, so it broke. So I can always attribute it to a one-off that today it just hit and broke because it just did. Because again, they can't feel it and they can't tell it's off. It's like walking with no feeling in your feet. And that's what we're asking patients to do with dentures. We're asking them to give us sometimes critical information about Centric. They can't feel their teeth touch. So again, while I'm talking, I color the lower anteriors. So remember I did that in that one video, and I colored the lower anteriors, and I'm watching her jaw posture. Well, that's no different now than what I do down here. Rotate image, and I can come, and now I'm doing a chew cycle and the patient moving, but I can also take this articulator and I can do a chew cycle, and I can shift it. So if you look at it this way, remember, a chew cycle's this way, but a chew cycle can also be anterior to posterior. So I can take this thing, and if you watch right here by my index finger, I can take it and I can move it this way, I can move it this way, but I can also move it anywhere in between. And you can do that even on a hinge articulator. I can take that, which now, instead of just our standard end-to-end, I'm taking this and I'm moving it. So what I would do is I would take a pen. So let's pick blue. And I'm going to color those lower anteriors blue, like that. And then I'm going to do a chew cycle. So sorry, I didn't loot them down yet. But let's just pretend, right? Okay, this patient comes a little bit more out to their left, so I can take this thing and move it. And then what am I looking for? Well, I'm looking for those little blue marks, okay? So now that's where I would go in and make that change, or those corrections where I can adjust, move the tooth, grind the tooth, etc., to allow more freedom for how I believe that patient to be posturing. And then if this comes back to you and the tooth is always breaking off, then this is what the doctor or you as a denturist need to do, is to check this in the mouth to catch that posture. Now, the trouble is these pens will bleed in the mouth, so because they're non-permanent. So the minute that you get them wet, the minute that you get the color wet in the mouth, this thing is just gonna bleed. So how do I check this in the mouth? So let me just show you a quick example. So I'll take this off with the Kleenex. So thank you. Now bear with me. It's a couple options here, okay? Option one. So option one is I take the dentures out of the mouth and I dry them, and then I can take the articulating paper and I can rub it on the tooth. So it actually lets me rub the ink off on the tooth. So I can do that, and I can do that up here too on the cusps. Let me do the buccal cusps here. So I can rub the ink off on the cusp to, again, do the mark like I would in the lab. Or, there's always an or, I take a cotton swab or a Q-tip by brand name, and I coat it in some petroleum jelly or some Vaseline. And then I can come and I can color the Q-tip, and then I can color the teeth. So then I'm just using the ink, and I can come in and color, and then I would introduce that into the patient's mouth and then get them to function and talk and chew. Now, you can get them to do green pepper or cucumber, because those foods aren't like bread where it's going to take all the marks off. Cucumber and green pepper as such are soft enough that they can facilitate a chew cycle, yet they're not going to take the marks off for me. And then that leaves the marks on, so then I can see where the hit is, and then I can do that adjustment. So for example, if this was an all on 4 or an all on 6 with repetitive tooth chipping problems, that's how I would calibrate it in the mouth. So I would get in there, and now I can't take the dentures out, but I would get in there clinically, dry everything off, go in there, mark everything like I just did with the Q-tip, or I can take in the mouth, I can at least do the front, and I can take the Q-tip and do the back, the posterior, and then get the patient to function for me with an all on 4 and all on 6, and then find those little, again, those little hits and slides. And then again, I have to get the light in there and a mirror, and they can be difficult to see, but I'm looking for the width of a human hair. And then I can adjust that intraorally without having to take the whole case off, which is a huge time saver for me. So these are little tips that I can give you to, again, help reduce your stress load, help reduce your burnout load. And so what I wanted to do on the class 2 was to show you that you can interdigitate different posterior teeth based on the level of the class 2. You can actually interdigitate different anterior teeth. So I can either go smaller, or if I don't want to go smaller because I don't like them because they're too small, then just turn a lateral or a central and bevel the edge off and turn that into a cuspid. Again, behind lips, it's going to look relatively the same to the patient. They're not going to see it. So the teeth allow you this flexibility. So our takeaways here, are number one, I want freedom and flexibility. So I use product that allows me to be flexible to the patient's needs. So I've looked at a patient and I've identified by looking at their jaw and watching them talk, and I'm looking at their jaw posture. So one thing you can do to train your eyes is when you go home tonight, look at your loved ones at the dinner table and watch them eat. Or when you're looking at the news, watch the newscaster or the reporters when they talk, and you're trying to look at their posturing and see it. The best is, of course, when you're at the dinner table at home tonight and you're doing this with your hands like this. Hi, I'm just watching you, and you can see someone chew, but you got to retrain your eye. It doesn't happen in 5 minutes. So the takeaways are, I use a product that allows me to be adaptive because I want to be adaptive to the patient. So I use a product that's adaptive to me, being adaptive to the patient. I've learned to identify a chew cycle and what that is. I've appreciated what freedom is now and how that works within a chew cycle and how that's moving for the chew cycle. And that freedom is good. So that's important. There's your wiggle. So it's important that we follow those things. And then I can calibrate it by, again, watching how I use articulating paper. Remember, when you put articulating paper in someone's mouth and you put it in, the first thing on horseshoe articulating paper is their tongue's going to hit this and it's going to retrude their tongue. So your bite's off. So don't use this in the mouth. So then you say, yeah, Mark, but then I'm going to use the calipers and I'm going to hold it in and then I'm going to do that. Well, what you've done is you've introduced something foreign into the mouth and pushed the patient's cheek out. And now their central nervous system is having to give you accurate information, yet understand that what's this thing pushing on my cheek? Don't do that. It's an external influence. Don't stick anything in someone's mouth, which is why I've gotten away from articulating paper and learned to color the teeth so that I get the information organically from a patient without interference. That's big, because then they can give it to me. And then what I'm looking for are the very fine lines and the fine marks, because that's all it takes to upset the apple cart, as they say. So the takeaways today are, I'm using a product and I don't have to worry about repolishing things because it's acrylic glass. It's going to do that for me. So that's another check off my list of things. It's also that the teeth are finding 3-point centric, so that it's, as VITA calls it, it's an easy find centric, which means all that does is there's a cusp and it sits in the fossa and it's tripoded and it's done. So you'll find that these teeth zip into centric really quickly, and then I don't care what cusp goes into what fossa. Just remember that if it's not sort of the designate, which means a first molar over a first molar, if I have to put a second premolar or a second bicuspid over top of say a lower molar, just the cusp is smaller. But what does that mean? It's a smaller cusp, but I'll get a little bit more freedom, but it's still a 3-point contact. It still sits in there. Everything's still the same, as I wanted to show you that. So it allows me that flexibility. It still looks aesthetically good to the patient because that doesn't change. The emergence profile doesn't change. So the benefit on the class 2 was being able to show you that I have all of these different things and different options available to me to be able to make that work for the case sitting in front of me without taking a great deal of time, because they'll just kind of tip in and tuck into each other the way that they're designed. So we have the easy find centric. The other takeaways then are, as I circle back to it again, is to identify your burnout and the issues that you're faced with every day and the repetitive issues that you're faced with every day, and then have those discussions with yourself and or with your doctor about what do we need to do here to help that. Because again, I want every technician out there to understand, every technician that's listening to me right now to understand that chair time, and my chair's over there, that's why I'm pointing at it, but my chair time is worth everything to me. That's where I make and lose money. The doctor, his technique and his talent is the chair side understanding of the patient, and you're there to back them up. So I wanted to show you the chew cycle and some of those idiosyncrasies so that you can set it up better now in the lab. So I'm asking you to switch teeth. I'm asking you to use VITA Teeth. I'm asking you to try it different. And then I'm asking you to track the adjustments and watch them drop. And to all the direct wet-fingered healthcare providers out there, the doctors, prosthodontists, and denturists that may be listening, it's the same thing. Switch teeth. And I wanted to show you now the benefits of them. But again, what you're going to see intraorally and the beauty of it, and again, the time benefit to you, that you can sit and stop and have a lunch because you saved 30 minutes today, and it's not overloading your schedule. Or your secretary's not coming to you going, Mrs. Smith called, we don't have any time today, so do you want to stay late? I mean, come on, we've all been there, and we suck it up for our patient because we're givers and we stay late or we work over our lunch. But again, that burns you out over time. And what I'm trying to, again, show you today was how to reduce that. And I look like Ross off of Friends. Bring it down a little. I wanted to show you that, to say, okay, these are the benefits of what I've done and what I've just through time and my OCD to figure out, how do I save time and be more efficient, and then understanding a patient. So remember, they have no nerve to their teeth. They can't feel it. They can't tell you that there is a hit and slide, where I can feel a raspberry seed right away, or I feel the hair on my teeth right away. They don't do that. And then we've been misdiagnosing it. So freedom is good. More freedom is better. A chew cycle, how to remanipulate an articulator. That's what I wanted to leave you today on a class 2 setup. And then again, the interchangeability of the teeth to make it work within that class 2. So Jim, how are we doing for some questions now?
All right, we do have a few questions. Before we get to them, let me go over with the group a few reminders. So we are going to, if you're interested in looking at the recording that we have, we're going to post it in a few days. So here, go ahead and look at our VITA North America YouTube channel. You can also have some links through the VITA social site as well. If you need to get a hold of us here at the group for the help desk, here is some information here. For the help desk, get a hold of us, ask us some questions. If you're looking for CE, those of you that are looking for CE, you will get a notice through the email, through the marketing education website about follow-up as far as your CE goes. And then if you need to get a hold of your local rep, VITA rep, here is some information as well. We have them in the U.S., also in Canada, or of course you can always call direct into the VITA North America, and we'll direct you towards your rep. We have some additional webinars. We have one with Mark later on this year as well. But we have plenty of webinars scheduled out for the rest of this year, all the way to the end of it. Mark is going to come back here December 16th and do another follow-up program with us, which is excellent. As you can see, Mark's very enthusiastic about providing you with information, and not just any information, but information which will help you out in the field, regardless of your background, whether or not you're a denturist, a technician, or a dentist. But please feel free to get a hold of Mark. Mark has graciously provided us with his information. If you need to get a hold of him, give him a call, give him an email. Probably best to give him an email first, and then let him follow up with a voicemail or something back to you.
Look me up on Facebook at Mark Wagenseal on Facebook, and then you could message me as well. Look, I'm here to support you, and I'm here to support VITA, and VITA's here to support me supporting you. And we're here just to amp up your superhero denture skills that you already have. And I want to give back and support a profession and an industry that I love. I love dentures. It's the right path for me. This doesn't freak me out. I love this. And I wanted to share that with you. And again, my journey to my triumphs and tribulations, as they say, and what I figured out along my path to make things less stressful for me. So I wanted to share that with you. So thank you for being open-minded.
Thank you. And thanks, Mark, for another exciting webinar. A lot of information, good information there. We've got a lot of questions, so let's get going on the question set. One is, what's your comparison setting up lingualized occlusion using the Ivoclar teeth? So what's the comparison between maybe Ivoclar teeth and the VITA teeth using that?
Yeah, okay. So look at you wanting to push me to be controversial right away.
It's an audience question. I'm just here to communicate.
That. Well, let's have that open and honest and frank discussion. This is just my opinion. My opinion's my opinion. Some people want ketchup on their scrambled eggs, some don't. It's not right or wrong. I like this better because it's acrylic glass. Ivoclar is not acrylic glass, so I got to polish it after. And Ivoclar, what teeth are you talking about? Is it veneers? Because not all their teeth have freedom and centric in them. So if you're looking at sort of their more baselines that are from the 50s, those are all not freedom and centric teeth. So I don't use that anymore. I've used products. I've used products from many different manufacturers, and I've settled on this because of what I've just spent the last hour and a half chatting to you about. So my opinion would be this is preferred over a different company because, one, I don't have to polish, two, it has freedom and centric and allows me that flexibility, and it's mortar and pestle, not the old 50s philosophy of milling. How'd I do, Jim?
Very good.
Without being too, I'm trying to be careful here, everybody, but I'm at these teeth for a reason, because I've tried the other ones and these work better for me.
Yeah, excellent, Mark. I mean, and the audience should know, as Mark, we don't have key opinion leaders because we pay them. We have key opinion leaders because they actually use and like our product. So we don't try to tell any of our key opinion leaders what to say or how to say it and so forth.
So let's have that discussion. So as a global VITA trainer, the one thing that VITA has told me that I must do is the wiggle. So I've done that. That's the only thing they want me to do was to demonstrate and again highlight freedom and centric, because we forgot about it. We haven't been talking about it. It wasn't something that we did back in the 50s. And that's again where I'm saying it's time to let that stuff go. we rarely use anything that's designed in the 50s anymore. Yet every day we're using denture teeth that do. I'm sorry. It's time to let it go. And so that's where I had to get out of my way and stop and say, wait a minute, what am I missing? And again, that's what I spent in this last time with you, was to very carefully go through why I'm here the way I am today and the way I speak about today. That's why. And I'm telling you, I dropped my adjustment rate to 0 to 1. It's consistent and it works because this is what I've done to get there. And that's what I want to share with you and share with the industry and my profession, because we can do and be better and challenge what we think we know.
Thanks,
Awesome.
Mark.
Next question.
Yeah. So you mentioned it, the patient's chew cycle. So
Yes.
many questions were about, well, if I don't see the patient, how do I get the dentist to communicate what that chew cycle is? Is it to use that symbol?
Yeah. So okay. So you draw it out, and then they can circle it. Look, this is difficult because I'm asking the dentist to look at a jaw differently instead of just the aesthetics that they look at. I need to get in front of them. So what does that mean? Well, you can show them this video and get them on YouTube, or send them the video of today, or specifically of that clip if you want to edit it out. We can come in and do an evening with your doctors. So if you're a large lab or even a small, medium lab, and you have a group of doctors, it's possible for us to come in and do a demo night and train them. That's one option too, where I'll come in and I can talk to them wet finger to wet finger about this. The other thing then are those crucial conversations that you can have with them one phone call at a time and say, hey, Dr. Smith, I saw this course. It talked about this fella from Canada, talked about chew cycles, and there's a couple of videos I'd like to show you just what that looked like. But can we start talking about that and you identifying that, or even have them send a video of that patient and then just thumbnail it and send you the video so you can see it. So just have the patient do the days of the week, months in the year. So you have some options there now that I just reviewed with you about how to get the doctor to identify that. I leave that up to you, what's best. Again, it's one critical phone call at a time, one crucial conversation at a time about efficiencies and getting out of your own way. And this is about our patient. That's the bottom line of why we're here. And we're going to move everything we can to help that patient. We're all on board for that. The team's on board for that. So those are some of the quick options that I can tell you that you can explore of what works best for you.
So another question for class 2, class 3, is the goal to bring that patient as close as you can to a class 1 without compromising that patient? Or
no, remember that was Lady Gaga. Baby, you were born this way. If you're class 2, you're class 2. If you're class 1, you're class 1. I'm just shoving the teeth around there to make them work in that classification. So I'm not set by the standard. It has to be a first premolar, a second premolar, a first molar, a second molar, and it has to stay over top of that corresponding. No, you got to make it work for whatever the situation shows itself, and then working within that chew cycle. I want to be clear. We do not chew in centric. Sure, my bite's right, Mark. My bite's right. Yeah, you don't chew in centric though. This might be right, but you don't chew there. You chew in a chew cycle, and that's where the hit and slide comes. So I don't try to set a class 1 into a class 2 or a class 2 into a class 1. No, you are what you are, and I just make it work to whatever you are. So I always smile, but man, it's Lady Gaga. Baby, you were born this way. And I got to let go of me. And again, how I approach treatment planning of a patient. This isn't about me. This is about them and what I can do to try and mold myself to them as much as possible to make the thing work.
All right, kind of a follow-up question is, when you have a class 2, class 3, do you follow more closely the parameters treatment plan of the upper ridge or the lower ridge? Which ridge is more prominent, if you will, to have to kind of follow and keep within that corridor
Yeah, good
of your
question. So I follow a lot. Remember, I go back to that model analysis and my belief and faith in golden proportions. So I really try to make sure that, again, that cuspid follows that Ruge line. That's a big one for me now. I try to do that. So I try to make sure that that cuspid follows around, because when that cuspid and the first Ruge line up, then I know everything else will. So it's not I guess you could argue to say, well, you're letting the upper dictate it, but remember, it's all golden proportioned. So as that person developed as a class 2, that whole system grew and developed and ratioed a class 2. So even though I'm letting the upper tell me where the canines go, that's still in relation and going to golden proportion itself to the bottom. What I didn't show you was all the finite lines that I do with a model analysis. I wanted to concentrate today a little bit more on how the teeth worked and the interchangeability of them versus the full-on model analysis that I do, where I actually draw specific lines on the model and then can blend those lines. So that also is a blend. But to answer your question, my dear colleague, is I typically, it's not so much one ridge over the other, because when I let the canines follow, that's going to golden proportion to the bottom, because everything's tied together on that golden proportion rule. Okay?
Right. Let's see. Another question is on the hit and slide. When you find that there's a hit and slide, do you usually burr modify the upper or the lower?
Yes. So you will always do the guiding plane of the bottom. So the guiding planes here on the bottom, okay, almost always. I don't ever want to try to cut the big cusp on the top. No, but sometimes you might catch a guiding plane here, so you might have to do it here a little bit, but you never ever want to touch the tip. Most of it's always on the lower. Yes, the odd time on the upper. So again, just to show you, that's the cutter right there, and maybe a little bit in here on that buccal cusp where it overlays. Okay, so sometimes I have to do that, but typically it's always on that bottom bowl, typically.
All right, good. And then have you come across any electronic digital bite simulation software that maybe you use or thinking about using?
Bite simulation. So are you talking about like MyBite or TechScan, or? That's a good
I
question.
guess
That's
anything digitally.
Because look, I have it like, okay, so the answer is yes. I have I even have a Digma, which is the digital model analysis that tracks the lower jaw. I've tinkered with that technology. Now there's the MyBites and TechScans, which are the bite fork that you put in, and it digitally tells you the bite strength and things. What I just did here was to show you how to calibrate that manually, because again, what I've learned now at my position now in treatment care is I try to not touch the patient as much as I can. Where before I touched them all the time, but now I'm not trying to touch them, because when I touch them, I manipulate the data. So if I touch their jaw or I'm holding them, I'm manipulating the data because it's an external influence. So to answer your question, have I tinkered with the technology? Yes, I have. I've just really as subtly showed you how to do it manually by letting the patient give it to me manually. Just remember, it's just they're very fine marks. Whereas if you're starting to use some of the digital technology, yes, it'll show it to you in a more clearer form. You have to interpret that. Just my issue is that then I've put something on their head to get that information, or I've put something inside their mouth to get that information, and that's an external influence that's befuddling the central nervous system. And I'm more cautious about that now. I have so much respect for the central nervous system now at my part of my career. I'm telling you, I am super respectful of patterns and again, a pattern and a chew pattern developed of a patient and then trying to break that habit. We're all creatures of habits. And so I've experimented with it, but I've showed you here how to do it on a hands-off approach manually. And it's still at the moment my preferred way.
So you follow nature, individual patient.
Yes.
Yeah. Good. All right, so we always get this question: what brand articulator do you recommend?
Right. So a Protar articulator, a Protar 7. So you can call Dent Tech Solutions in Canada, DENTTECH, Dent Tech. Talk to Derek Smith. He's going to love me for dropping his name. But I know Cavo America sells them as well, but I know the rep up here in Canada, of course, since I'm Canadian, so I'll give him the shout out. But it's a Protar articulator. I will be very clear, though, a Stratus 300 also does this. And again, it's just a Protar versus a Stratus. It's just now, what do you like better, Heinz ketchup or your Superstore brand ketchup type of thing? They're very similar articulators, but a Stratus 300 does what I showed you, or a Cavo Protar 7 or 9 does it. So either or.
All right. Thank you very much, Mark. It was a great presentation, as always.
Right. Why, thank you.
Remind everyone, Mark's information is on the screen. You certainly can get a hold of him if you have some follow-up questions. Please do so.
Here to support you.
Yes, and again, Mark is going to have another webinar in December, so please join us for additional webinars. And you can always visit the VITA North America YouTube channel and review today's webinar, or go back on several other webinars. Probably maybe 8 of them, I think 9 of them this year so far, right, Mark? Yeah. That we've done. So they're all different topics, so please join us.
Watch, share, help our profession grow. Help our profession be better. Help our profession and yourselves be that superhero and that denture superhero. I love dentures, and they're not the end of the road. And you don't need to stick them on an implant to be successful. So thank you for hearing me out. We don't slap teeth together. Woot, woot. Remember, freedom is good. So thank you for investing in yourself.
Well, you are good, Mark, so appreciate your time, effort, and I want to thank everybody for joining us today, and everyone have a great the rest of the day wherever you may be. Mark, thanks again.
Awesome.
And
pleasure.
This will conclude today's VITA Learning webinar with Mr. Mark Wagenseal. Thank you.
Bye, everybody. Thank you. Woot, woot.